Good afternoon, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to welcome you to today's review of the 2019 CMS Interpretive Guidelines. We're so pleased that you could all join us as we have what's bound to be an informative discussion coming your way. But before we begin today's presentation, there are just a few logistical items that we'd like to review. For optimal visual and audio experience, these webinars are best accessed in the Chrome browser. So if at any point you encounter any audio issues, we do recommend logging back in using Chrome. If you continue to experience any issues, please dial in using the phone number provided in your confirmation email. Now, for those of you who have never joined us on this webinar platform before, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat can be used to pose your questions to our speakers. So if you have any questions that come up during the course of the presentation, please feel free to submit them at any time. Once the discussion concludes, we'll have some time for our presenters to address as many of your questions as time allows. Now, for those of you who may be interested in our upcoming webinars, registration is currently open for our next webinar, which is entitled Anatomy of a Donation Champion. That's coming your way on May 14th at 2 p.m. Eastern. Registration also just opened for our innovation webinar series entitled Bridging the Organ Gap, Breakthroughs in Tissue Engineering and Regenerative Medicine. Be sure to tune in for that on May 23rd at 2 p.m. Eastern. Lastly, we have our transplant webinar that's also open for registration, and that's entitled Confronting Stigma, the Impact of Substance Use on Organ Transplantation. That's coming your way on May 28th at 3 p.m. Eastern. You can register for all these webinars and more on our website at organdonationalliance.org. Now, at this point in time, I'd like to introduce our moderator, Belinda Jones, Program Consultant here at the Alliance. Belinda, thank you so much for joining us today. And at this point, I'll turn it over to you to introduce our speakers.
Thank you, Deanna. We're excited to have Kathy Schwab, Kristine Browning, who will be our primary presenters for today's webinar, and they are presenting on behalf of the TQI. Thank you, Deanna.
Hi, this is Kathy Schwab, and I just wanted to make a couple of comments before we get started. But we do strongly encourage you to put your questions in and raise your hands as we're talking. While we are being the presenters, that doesn't mean we have any more direct knowledge than the rest of the audience. And so I think collaboratively we can come to better conclusions than if only one of us speaks at a time. So now I'll let Kristine take over.
Thanks, Kathy. So today we're going to talk about what we identified are some changes in the new IIDs and what are the differences. And then we're going to have our experts, Gwen and Luke, pipe in on the rule versus the guideline. So back in September 2018, the COP released this proposal. The CMS released a proposal which was intended to remove the red tape of patients over paperwork. And I just want to be clear that none of these proposals have gone into effect with the new interpretive guidelines. And this was including the X042 tie-dye form requirements, the X43 minimum transplant volume, and X45 SRTR flagging. So these all remain in effect at this time. So that's very clear that none of these have been applied in the new interpretive guidelines. So March 29th, the release of the Memo QSO 1911 Transplant was released to the state surveyors. We are aware that starting in January 2019, that all of the CMS transplant surveys moved back to the state agencies. So then with this release of 329 came new interpretive guidelines. And I know there's been a lot of questions about, is this in addition to the guidelines? Are they in effect? What is the difference, and when are they being implemented? So we're still waiting on final confirmation from CMS, but we did hear that these are the guidelines. that are going to be in place, and they will be finalized shortly. And from what our understanding is they've already been utilized in some center surveys. That they are to supersede the 2008 interpretive guidelines. When we look at the document that was released, the red italicized material means that these are the revised items, and then any of the previous material published will remain unchanged. There are a few tags that were noted to not be in the document at all, and these are really titles. And just as a note, remember that X72 was removed back in 2012. These tags were noted to not have any revisions or additions in the current memo release, and these are the list of them that are available for you later. The first tag we want to highlight of notable changes is tag X074, Living Donor Verification. In here there are several items that are of concern that we have regarding the verification of living donor. One of those specifically is that the requirement is that the transplant verification of the living donor must be done by the transplanting surgeon. Also that this must occur on site in the donor OR room prior to induction of general anesthesia, but also immediately before removing the living donor organ. So verifying the organ in the pre-op holding area may be cited with this, but how much of this is within the regulation and how much of it is the guidelines?
Kristine, this is Kathy. One of our surgeons at our Arizona site did have a conversation with CMS regarding that transplant surgeon. And as we all thought, that was a misprint. It should be the recovery surgeon, not the transplanting surgeon.
So it definitely is a misprint. That's what I assumed as well.
It is a misprint.
Okay, great. Just as a note, I did pull out the OPTN policy language that went with this, and the OPTN policy language just requires the day of the surgery. I can tell you historically one of the reasons I had reached out to CMS regarding this requirement that the donor had to be in the OR room is because there was a swap from when the patients were checked, the living donors were verified before they moved from the pre-op holding area to the OR suite. And so that was what might be behind that, but again, is this outside of the scope? The second tag that we wanted to talk about is the phases of care. There is significant overlap, and these are actually less clear than they were before. So when we look at the actual transplant phases, they're saying it begins when the potential transplant candidate is evaluated. We don't really know what that definition is as far as candidate is evaluated. Does it mean when they first come on site, when they finish the eval? What I did find in the CMS survey are lessons that are offered online. They state after transplant has taken place, the patient moves to the discharge planning phase because, again, there is this overlap of the discharge phase initiating when the patient's first admitted to the hospital. And this could be for some patients, like liver or heart patients that wait some time in the hospital. This could be a really long time that this would fall under. So those are just some of the things that we had thought might be of concern there. So there is definitely overlap.
So Gwen or Luke, could one of you comment on what you think when they say at the initiation of the evaluation, where would you expect that to begin? Is that something we as individual programs should define for ourselves, or do you believe there's going to be an expectation?
This is Gwen. I think, yes, you should define it for yourself. And this is just my opinion, is as soon as the patient either sets foot on your transplant center or is with the intention of either getting a transplant or being a living donor, or they start doing testing with that intent, you've started an evaluation.
Okay. So you don't think it means when appointments are made or when they make the initial telephone call?
You know, just the initial telephone call, like that I want to come in to get evaluated?
Yes.
I don't think so.
Good. what I wanted to hear you say.
But I think we're going to talk about this in a minute, but I do think we need to, well, we'll wait till we get to the ILDA part.
Okay.
I think in general that what in the, certainly in payer language and in practice, I think that when they call before they actually come in or start testing, we generally call that referral.
As do we, but there's no opportunity for referral when you look at these.
Right.
So, very good. Thank you.
Okay. So moving on, when we look at the living donor care phases now, with first presentation by a potential donor until the time they enter the OR, and then they do have the donation phase from the OR to actually it is also an overlap, discharged from the inpatient surgery stay. And then again, the discharge phase is defined similar to the transplant. But what does this mean, presentation of the potential donor? Does it mean when we make the appointment? Does it mean when they come for their first visit? Gwen, did you want to talk about that?
Well, sure. I mean, I think the word presentation would mean first time that they came to your site.
Yeah. Okay.
I think I think that's kind of goofy because a lot of donors start their evaluation, start getting like initial ABO and chems and that kind of stuff before they ever come on site. But presentation to me would mean they actually show up at your site.
Okay. Thank you for that.
This is Luke. I think part of the reason that there is such confusion here, you can see in the living donor phases that they have this evaluation phase. They don't have that for recipients. The reason for that is because they explicitly decided in making the final rule to limit the regulations with respect to the pre-transplant, or what they're calling here the evaluation phase. And so some of this conclusion, in my view, is coming from the fact that they inappropriately extended the transplant phase on recipients back to include evaluation, which I consider completely incongruent with the final rule, and you can see that in the conversation in the Federal Register.
Correct.
Thank you. Yeah. Okay. So the next notable tag we have is the multidisciplinary discharge planning, X091, and when we first look at what the change is that they actually include specification to financial being involved in the discharge planning. And really the question is, who could do this? Do we as a center define who would be participating in the portion of addressing the financial needs, meaning the social worker, your financial specialist or coordinator? So, and I know for our center, our financial specialists are really not involved very much at this stage unless there's something specific that comes up. Does anyone else have any?
I would hope that that's going to be allowable for the social worker to kind of do a brief update that everything is in place and that their meds are covered and so on and so forth. But we'll have to see.
And then they talk about the nutrition plan, and the question is they need a specific the transplant recipient or living donor has to have a specific nutrition plan as applicable. So, who is addressing that nutrition plan? Is it the RD requirement, which we'll get to in a minute, or, and how long would they need this diet factor? This is just the rest of the multidisciplinary, which it does specify out, but I believe the majority of these are things that are addressed in our population regularly. Now we move on to the nutrition tag as far as the language of the requirement of the dietitian. And I read this to tell me that it gives us a little more leeway as far as the needs for nutrition. Is it just the RD that is required to do it, or is it now allowing for the team to actually consult the RD when the time is identified that the patient needs the diet assessment? And I think that our center actually has criteria of what patients would be needed to have, what criteria would need a nutrition assessment.
I think where the conflict is in other parts, they specifically say that the members of the multidisciplinary team have to be involved in every phase. And that's certainly, and of course, it's different surveyors now, but that's certainly been how they've enforced it in this past cycle.
And I think this was one of the top sightings, is the RD was not involved at every phase of the care of the patient.
So are you suggesting that we have criteria developed individually by a program saying the things which would require a nutrition consult versus nutrition following?
That's how I read it, that the nutrition needs to be available, but that anybody on the team can consult them at any time and bring them in to address the needs.
That was how, I think, the initial 2008 IGs, that was how that was interpreted, and a lot of centers did that. And, past surveys with that, based on criteria. I know we were surveyed, I guess 2 years ago. We got cited on it. That we didn't have the dietitian specifically. They didn't have to write a zillion notes, but they needed to at least write a note. Has no dietary needs. We'll sign, ready for discharge. Unless circumstances change, we'll sign off.
And so they could do a chart review as opposed to having a face-to-face visit.
Yes. Yeah, that's always been okay.
Yeah.
Okay. So Gwen, you want to go ahead?
I had the phone on mute. So this is there's a couple of tags that have to do with the responsibility of the director, and by director they don't mean like the job that I have. They're talking about the physician director of a program, and they don't mandate is that a surgeon or a physician. In the top part of this has the actual standard, which uses the word coordinating. So they're giving the responsibility, the overarching responsibility of the making sure there's an adequate training of nursing staff and transplant coordinators in the care of transplant patients and living donors to the director. But coordination can mean, it does not necessarily mean to me hands-on involvement. When you look at the interpretive guidelines, they're specifically saying that evidence of coordination should include the transplant director has participated in the development of training and orientation plans for nurses. So that they're actually writing them, and that they're actually offering training themselves. And the last part, which I found most problematic, was the transplant director provides feedback to the nursing department on the clinical competency of the nursing staff working with transplant recipients or living donors. I think that's well out of the scope of what the actual regulation is. And I certainly, as a nurse, and happy Nurses Week to everybody, I have a real problem with physicians determining the competency of nurses. The second tag having to do with directors, I've highlighted that the guideline is that ensuring the transplant surgery is performed by or under the direct supervision of qualified transplant surgeon in accordance with blah, 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 and that the surgeon has to be credentialed. They specifically called out here that if a fellow resident is in the surgery, the attending surgeon must remain in the operating room or be physically present in the operating suite. I think that's not as clear as an overreach, but I think that is problematic to many academic medical centers if this is going to be interpreted skin to skin. It's just not the usual practice of many busy academic medical centers.
I think that's a key point you're making there, Gwen, because I would be willing to bet in most places skin to skin does not happen with the attending. think you were going to do that one too, right, Gwen, the ILDA?
Oh, okay. Sure. So I think this is something a lot of people are concerned about is, if you look, this is a really nice slide, that the living donor advocate or living donor advocate team must not be involved in transplantation activities on a routine basis. I think over the years we've all pretty much got a good handle on what that meant, and it was also fairly well spelled out in the 2008 interpretive guidelines. In the March 2019 interpretive guidelines, they have this phrase, must not be associated with the transplant program in any capacity. That seems very, very restrictive, and in many places will be very difficult to actually implement. That they couldn't even sit there. I mean, we're responsible for training them. For the most part, whoever gives these services has to be reimbursed in some way, and they're just generally going to be reimbursed from the transplant center. I just think that it's going to be very difficult for transplant centers to implement, and doesn't seem to be consistent with just must not be involved in transplantation activities on a routine basis.
This is Kathy, and I just want to step back to one of the questions that was asked regarding the prior conversation, was that are we sure that transplant director is intended to be the medical or surgical director? And I think if you read the COPs, it's pretty clear that it has to be, it's physician that they're just talking about, not the operations or the administrative director.
Yes, because the actual standard is the transplant center must be under the general supervision of a qualified transplant surgeon or a qualified physician director.
Sorry, there. Okay.
So it's actually written in there that it has to be a surgeon or a physician.
Right, and that's not IGs, that's the actual regulation itself.
And the other question about whether or not the independent living donor advocate team could include the living donor coordinator, I don't believe they can act as a donor advocate because they are a member of the multidisciplinary team in their role as a coordinator. It doesn't mean they can't be engaged with that team, but they couldn't act exclusively. One thing Kristine had said earlier was the definition of program versus center, and I think many of us either have institutes or centers. And what's the possibility, Gwen, I'm kind of asking you this, Luke, what's the possibility of having someone from the heart program act as an independent living donor advocate for the kidney team, the kidney program?
That specifically was said that they could not do that in the past. Now, okay. I think that's something we're going to have to clarify with them.
So I did pull these definitions from one of earlier documents that's posted on the CMS site for the surveyors to learn from, and they defined out a transplant program as a specific organ program. And so I'm wondering if there is the potential that you could have an ILDA that's on a different team that has no association with that organ program, but a different organ program. So we're going to be asking that, but because this really restricts a lot of our functions.
And I think you'd have to be very careful your reporting structure under those circumstances. They
yes,
couldn't report to the same person.
So I'm just going to go back because we actually skipped this one, which was the tag 121 for the living donor has to be assigned and have an interview with an ILDA prior to the initiation of the evaluation. So this is definitely out of the scope, Luke?
Yes, I think absolutely, and part of it points out the silliness of how broadly they've tried to describe the phases. This actually, in my view, becomes literally impossible based on their definition of when the phase begins. We would have to have living donors advocates psychically know who potential donors are and go to their houses, talk to them. Otherwise, we would fall out of compliance one way or the other. So, yes, absolutely, in my view, I consider this something that should necessitate actual rulemaking and burden analysis rather than be something they just insert into the interpretive guidance. I also don't think it's a particularly good idea, but that's neither here nor there.
Thank you, Luke. So we'll just skip ahead to the, I don't know if did we finish this conversation, so we go on to the ILDA training, Gwen?
I don't see any more questions.
Sure. So as part of the ILDA training, well, the key is that they're going to assess that the ILDA would be trained by interviewing living donors. So I want to set that up, and I think that's a little different also. So the particular elements that they're looking for is the organ donation process, the requirements of informed consent process, the immediate long-term expectations following donation, the immediate and long-term risk of donations, that's all fine. But then the expected outcomes for the recipient. And it doesn't say recipients, it says for the recipient. That, to me, goes outside of HIPAA as far as telling the donor information about the recipient. And then the potential financial responsibilities, that seems fine. But I find that the expected outcomes for the recipient problematic. I think you can give them general information about recipients in general, but not the word, having the "the" there insinuates that they have to know about expected outcomes for their recipient.
Kathy, were you going to take this one?
Yeah, I will. So then we're going to move on to X125, which is on page 107 of the IG pages. And it's talking about the pharmacist. And whereas it's desirable that each multidisciplinary team include a pharmacist member, there may be other disciplines on the team who may also be qualified to provide pharmacy services. So this is a change, and I think it's another one of those slippery slope changes that they have made. Who is better qualified than a pharmacist to review medications and look at side effects and potential issues that may resolve? But I think it is giving you leeway to say that your medical physician or your surgeon may be able to fill in certain cases, but I don't know that they intended for the pharmacist to be completely outside of the team. Gwen or Luke, do you have a thought on that?
So the language has always had a little bit of fuzziness in it, and my understanding of that from the beginning was related to the idea that clinical pharmacology is another specialty. And so I believe the original intent was to allow a physician pharmacologist to serve in this role. I think as it is written now, it has gotten very broad, and I usually don't complain about less restrictive regulation. And obviously, we could still all choose to have pharmacists at our center, but I think in general, we should be sticking with the original intent, which would include pharmacists and actual clinical pharmacologists, not a broader definition that would allow other physicians and advanced practice providers to fill this role.
I'm in complete agreement with that one. Any questions? I don't see any questions on that regarding from the group.
So I do see a question going back to the living donor advocate. It says, can the living donor advocate have another role in the living donor team, such as social worker? That's certainly how it's been practiced previous to this. I think that's something we're going to have to push back on CMS about. Now, there couldn't be a social worker that was seeing recipients, but certainly many social workers are ILDAs and serve as the doing the psychosocial evaluation of the living donors.
Okay. I can't advance.
Okay, I'll advance for you.
Okay. So then X151, starting about the evaluation of informed consent. And as we've always known, part of the informed consent process is ensuring the candidate understands what the evaluation process entails prior to its initiation. And therefore, I think it's prior to its initiation is where the questions come in. Does that mean immediately when the patient steps foot into your institution that there has to be a discussion regarding informed consent? Does there have to be some type of discussion had with the patient on the telephone prior to their coming to the program. And I think this is going to be one of those pieces where, at least I think our program may have to change the practice that they currently have, which is they go ahead and get their labs drawn, and then they talk to someone about the informed consent process. But based on what it says here, it says prior to the initiation. Anybody have a thought on that one?
I definitely think it's going to impact a lot of centers because I think that probably is a common practice for patients might be sent an informed consent mailed out and they come on site, but they're traveling from far away. And, you know, they want to get through their eval as quick as possible. We have to do labs first thing in the morning, and, you know, it's not like we have people there at 5, 6 o'clock in the morning to sign a consent or have a discussion. You know, one thing Kathy and I talked about was that, you know, our center has a phone conversation with the patient telling them what to expect before they come on site, and would that be considered enough, as it is documented in the chart, as the candidate potentially having an understanding of what they're going to go through?
I have a couple of the concerns here. One, anytime they use language like ensuring the candidate understands is problematic for me. That is a challenging word, and in fact, in part later they say prior to undergoing an evaluation, they must understand. That's actually, as written, not a regulation of the transplant center, but a regulation of the candidate, which is of course not permitted by the final rule. So that language in general is problematic. I also think this type of language undermines the idea of informed consent as a process. It's Congress to say part of the process is to ensure it, and the process is ongoing, and informed consent does not stop at a signature on a document. It should continue throughout the evaluation process, in my view. The prior language, where it said that things had to be discussed, is very reasonable. This new language, I don't think is supported by literature on informed consent, and I think is not consistent with the final rule.
So, Felicia, I think we all have that same question. What does initiation mean in relation to this? So I don't know that we have the answer to that. I do know that there are multiple people who are in conversation with CMS regarding things, and this, I'm sure, will be one of the things that is brought forward to them. And like Stacy is saying, that would impact you from accepting outside labs prior to an evaluation. So there's a lot of components to this that I think we have to work out with them as we move forward. You want to go to the next one, Kristine? Hey, well, now we're looking at 153 Alternative Treatments, which this kind of surprised me because I never thought this was an enormous issue, but prior to a candidate undergoing an evaluation, you have to describe to them alternative treatments should be reviewed. I think many of us have this as part of their informed consent process, and I'm hoping this isn't going to be a big issue for the majority of us. Anybody else have a thought? I think everyone knows that, particularly for kidney, the alternatives are dialysis. The alternatives for anyone at any time are to not proceed and just to continue with end-stage disease treatment. Do you think it goes deeper than that?
No, I would say that it can't. In my view, it should. An alternative treatment discussion ought to be something that is more personalized to the patient. However, if you say that it has to occur prior to evaluation, we don't know enough. And so I think what this will lead to is, as you described, a much more generic description of alternatives that you not get a transplant and live with the disease, or in the case of kidney, stay on dialysis. It's only after we get into the evaluation and get to know the patient that our clinicians can offer a better description of alternatives and the relative risk benefit. I think this is not in the interest of patients.
Right. And in many cases, this should be done by the referring physician before they ever even approach us.
Yeah, that's right.
Okay, you want to go to the next one, Kristine? So 155 SRTR Inform prior to eval, and that's on your page 119. And it's indicating that prior to undergoing evaluation, that we need to inform patients of not only the location of the SRTR website, but explain how they can use the SRTR website, which is not easy for, I think, most anyone if you weren't familiar with it. The new site, I think it's going to be somewhat more patient-friendly, but still it's a lot of hunting and pecking around, figuring out what you want to know. The other piece that we wanted to point out, and many of you probably already do that, but when you are giving patients data, you also are supposed to be giving them the expected, not just your center and your national survival statistics, but also the expected for your particular program. So I know that we tend to send the SRTR data out in advance for people to review. On that, we do have the website and how they can access it, but there's not specific details on how they can use it. Do you feel that this is going to need to be detailed out further by that initial approach? Gwen or Luke or Kristine?
I just think it's so hard to explain to patients what expected is. A lot of people, it's hard to explain to a lot of medical personnel. So I think that's one thing we hadn't included in our notifications is the expected values because it is confusing. But I also do think it's very hard that we're going to be trying to include in a letter to them or in education before they arrive how they can use SRTR website. This is hard. I don't know how it can be applied.
Well, and I think so many patients don't read most of that stuff you send them anyway. I mean, you can send them pages and pages and pages, and when you're not feeling well, the last thing you want to do is read through a bunch of complicated information. But that's just my thought.
Well, I think there's the ways that, well, again, it has this prior to undergoing an evaluation is a little bit problematic, but I mean, I like that it wasn't as prescriptive as formally, like you could just say get in the website. But from a patient-centered perspective, I think that's terrible. Really, I think for the patients, you need to have, like, what we give them is something that we have the website on it, so I think we'd be fine. But we actually explain a little bit more what these numbers mean.
Right, because it's very specific to the program and to the individual patients you're transplanting.
Right. So this is just going to let transplant centers say, oh, here's the website. You could look up stuff here.
Right. Yeah. Go to it. So then tag 161, talking about the living donor evaluation, and again, that's on page 124. And it's asking that the informed consent process ensure that the donor understands what the evaluation process entails prior to its initiation. And for me, and maybe for many of you, it's that prior to its initiation that causes the most confusion. So do we need to ensure before they arrive, or when they call in and ask to be considered as a prospective donor, do we have to go into significant detail with them at that time about what the donor evaluation process is going to be? And then do we have to document that, or can that just be assumed? And I'm very confident it can't just be assumed.
Yeah, I think maybe we have to, as a center, define in your policy what is the initiation, what is considered the initiation. But I hate to put ourselves in a box.
Right. You hate to define yourself into something you can't meet.
Yeah, because it can occur so many ways. Patients might have testing by their local physician. They might have, work done before they ever show up on site, lab works and what have you, especially for living donors. If you're doing the blood testing before they arrive, so you know that you don't have to go further or you can proceed.
Right, and I noticed one of the comments was that they have essentially most of their evaluation done prior to coming to the transplant center. So then you're way behind according to this particular tag.
Yeah.
So again, we'll hopefully have more information going forward.
Well, I think the sloppiness of this is really on full display here. In this very guideline, it has all these requirements of what happens prior to initiation of evaluation, and then immediately in the next paragraph says it begins at the time an individual is identified as a possible candidate. So I don't understand how you reconcile even this interpretive guideline on its own, that we have to make sure that the donor understands the evaluation process prior to being identified as a candidate. So now we're limited only to evaluating living donors who come in de novo with knowledge of living donation. So other than people on this call, it's going to be challenging.
Yeah, Luke, I think you need to tell us how you really feel. I like your terminology.
That's the darn problem with Luke.
So then, of course, we have donor-informed consent further, but some of the things that they require that we discuss with them, and one of them is how is the surgery expected to improve the potential recipient's health or quality of life. I think that goes back to Gwen's thoughts about HIPAA. I mean, how can you say, well, your recipient has X, Y, and Z, and so this should improve Y and Z at least? And how long will the potential recipient be hospitalized? Again, that's really not any business of the donors based on HIPAA guidelines. So I think that's something that we need to push back with. We can provide them with information of what standard length of stay may be, but I don't think you can or want to be giving them recipient-specific information. The recipient can tell them whatever they choose, but that's not our place to be doing so.
Well, I think this has got to be a typo, because they don't have how long will the donor be hospitalized. I would think that's the key part of the surgical consent. So I'm thinking this is one of several typos in here.
I agree, Gwen.
Well, let's hope that this is a typo. And then 165 living donor informed SRTR prior to evaluation. And again, it's talking about before they undergo that we have to tell the potential donor where the SRTR information is located. And I think the conversation resides much how it was with the recipient. You know, are you giving them the information? Do you provide them with opportunity to where the website is? But as far as trying to map them through the web page, they'll have to do that on their own. And then hopefully this won't become an issue for any of our programs.
Okay. So there was a question to repeat what does red italicized mean, and it is that it indicates a change, and then the final format will be available online in a few months in the State Operations Manual. So again, red italics indicate a change to the IGs.
You know, and that's what they say, but some of them are the same thing. So that's what made it so confusing, and we weren't sure, are these supposed to be replacement or so. I think actually it doesn't mean much of anything, really.
Yeah, I think we went back and forth whether is this in addition to the 2008 or is this replacing, and it'll be interesting to see the final document.
Well, they told me today that this supersedes 2008.
Yeah.
So, Gwen, did they indicate to you, or did you ask, are they going to put out a more complete-looking document, or are we just going to be hunting and pecking through it as it's currently written? I'm sure they didn't.
They didn't say that.
No.
And I didn't ask, are you going to put something that looks a little more decent than this?
Okay. And we don't really know what the effective date is going to be. We know what the issuance date was, and we know that they say that they have been implemented. But at the point in time when we're expected to be able to say on July 1 you have to be compliant, I don't think there's any information out there related to that.
No, and then several people have provided that they're already doing surveys with these IGs. This is what was given to the state surveyors to go by.
Right.
And
some of the members of this team are going to be having a conversation with CMS, I believe, next week. And so I'm hoping that these questions will be part of the discussion that's going to occur.
So there were a few questions that were submitted ahead of time, and one of those was for the document list, will it be actively listed patients, which at the end of this presentation and actually at the end of the document that we provided with the comparisons of 2008 and 2019, it does compare the document list from 2016 request to the one that was released at the beginning of the document on the 29th of March. And so it is the actively listed patients, and I believe that is a typo for the age for your waitlisted patients at time of transplant. I believe it's just the request is the age. When looking at the survey education documents, it just has age. So hopefully that answers that question.
And I see there's a question about the survey interval is now listed as 5 years. Yes, that is my understanding. And I've heard that from other CMS people other than in this document. But this document definitely says every 5 years.
I know I've spoken with 2 programs that have been involved with a survey since January, And the one in particular said that when they came in, the document list was given to them verbally, and it wasn't even all the items on the document list. And then as they were going through the patient tracer, which seems to be somewhat of a change, it's going to be more like the state would survey you for CMS, and that they kind of do a patient tracer through the process. As they get into pieces of the tracer, then they'll ask you for your selection criteria, or then they're going to ask you for the qualifications of your ILDA. But it's not quite the same way that we have had it happen in the past. Now, that's one state, one program, I recognize that, but it may be an indication of things to come.
Kathy, I think that also in this document, too, is that they're not asking for, they're just going to say, we want access to your policy and procedures, but they're not going to ask for them all up front.
Mm-hmm.
And that aligns with what is being taught on the CMS survey lessons. Specifically also for QAPI, they're going to review and ask for your AE log and trace a couple of those. And they would only do a full QAPI review if it was warranted, because if they didn't find things were completed. So that seems to be the consensus for a lot of the items. And also on that site, there's also an option you can actually click down resources and see and document an example of their tracer, what they're looking for, all the specifics of everything. And it looks like as long as everything's in place, they're really focused on the patient experience, that the patient understands at every point that this is the right decision for them, this is the right center and the right decision for the patient.
And Anne, these slides are going to be sent out to all of you via the Alliance, so that they'll be available for everyone. And Andrew, when you were asking what does prior to the evaluation, I'm assuming that the ILDA can interview the potential donor is a telephone interview in advance for particular pieces. I don't know that that's something anybody currently does or is interested in looking into.
And yes, an A log is an adverse event log. I think Kathy sort of answered this, but I do know somebody, to Nick's question, I do know somebody that was surveyed using these new IGs, and no, they did not mention that they were cited for this. I think actually the surveyors, this was like their first time doing it, and it sounds like they were fairly lenient. They brought up some of these things, particularly the ILDA not working in the transplant department, but I don't even think they got cited for that.
And for those of you who are members of the TAC, are you planning to do a crosswalk? Between the UNOS and the CMS guidelines as we'd had previously? I don't know. I'm hoping that will be the case.
Yeah, it would be nice to be able to see that again, but we haven't seen one of those updated in quite some time.
If we've got a minute, I wanted to point out just one other thing that I thought was concerning on page 18. I'm sorry, I should have made a slide for this. On page 18, under tag 81, it says, some transplant programs perform living donor services under arrangement with other hospitals. In these cases, the transplant program retains all responsibility for compliance with the management of the living donor. The transplant program must communicate the donor management activities that are required as part of the living donor organ recovery to the hospital under arrangement, ensure that the activities are completed appropriately. This seems completely outside of the scope, and in fact, it contradicts previous memos that CMS has put out specifically about people that do the adult donors for children's hospitals or for KPD. So that's something we're really going to have to work with CMS on.
And for the person who asked the question whether or not they should define initiation and presentation in their policies, Luke, I'd like you to kind of offer a thought on that. Would you do that in your policy?
Yes, with the aside that I still have trouble with the concept of this existing, but absolutely, and that's going to leave you in the strongest position, both in the conversation with the surveyor, to say this is within our discretion to define this, and so long as that definition does not fall outside the regulation, that is within the discretion of a center. So I would define it clearly in policy so that it's very easy for you and your team to make sure that that time point, what happens before it and what happens after it, are consistent with the regulations. So I absolutely would define it at the center level.
And I personally don't know of anybody who's been cited for not providing consent prior to evaluation beginning, but I'm not saying that has not occurred at some point in time.
No, I think the people, but also people are really good about giving some beginning informed consent before they do much of anything. I think we're all pretty good about that.
Yeah, I do too.
And that's never been one of the top cited items that's been reported by CMS.
So someone asked where you can find the tracer document. If you go to this link for the server training and you actually open one of the lessons, on the left side there's a menu. On the left side there's a menu right here that you can see, and you just click on those. So this is an old document. This Appendix X is an old document that was drafted in 2018, September 2018. This is the survey protocol, and so this actually walks you through the tracer. And then there's a short list of the transplant tags, but this is the whole operating manual. So. Does anyone know the answer to this question regarding the definition of when you need to report to CMS for inactivity? Because UNOS defines it very clearly, but CMS, I could not find it in the document.
If you can field another question, I can look real carefully. I kind of know where that is in here.
So just to be clear, the 2019 interpretive guidelines will supersede the 2008 version, if that didn't get caught already. I'm just going through the list that we have here. Someone had asked if anyone had a new set of chart audit tools to share, and at this point, I know I don't have anything yet. This is all very new, but surely we'd love to share if we do develop anything.
Right, and I would hope people would use the listserv to get out information that either changes how they interpret things and or changes that they're making, or if you've been surveyed by the state surveyors and don't mind providing some more information, I think we'd all be very grateful. Yeah. And the question about 5 years, it was stated right at the beginning that, and it's in the surveyor training, that it will be a 5-year period unless there's a for-cause reason to do so in the interim.
Someone else had asked about tag X33, how they don't list out adult kidney, but that's referenced in the 036, which the 3 transplants are required in a 12-month period prior to the initial approval, and to my knowledge, that hasn't changed. It seems like it's the same language it was.
And the question regarding the primary surgeon staying through the transplant case, I mean, it says they either need to be in the operating room or in the OR suite. So whatever OR suite might mean. Inactivation is X015. On receiving notification of significant, CMS will follow up with Transplant Center as appropriate, including but not limited to requesting additional information. But I don't. Is that something?
So I think that goes along with, if you look at, this is all under 482.74. So for the purpose of this, that's on page 5. For the condition of this, for the purpose of this condition and its relative tags at X12, 14, and 15, and 15 is inactivation, immediately means within 7 business days.
I agree. It does, as far as for the surgeon's location, would require some interpretation or more clarification. What does OR suite mean? It doesn't mean in their office in another building. I know that, but does that mean can they be in another room starting another case? I would guess yes.
So someone was asking about what do you define the ILDA interview as. I think that you could define that in your policies or protocols as far as what that's defined as, because I don't believe it's a requirement for an entire consult from the ILDA, but maybe a discussion, a telephone call or something. But again, this is outside the scope of the regulations, as Luke had mentioned earlier.
Yeah, I have trouble with that one, even conceiving of what regulation they would cite in attempting to cite a program for this. I'm not sure. I honestly don't know what citation they would make. I think that's always something to keep in mind. They can use the interpretive guidance to guide their evaluation, but when they want to issue a citation, they have to do that under a regulation, not an IG. And so it's always relevant to look back at what the actual regulation says to conceive of how they would even cite you. And if they're citing you, they can't cite you using language in the IG, and think of how a citation would read using the language of the regulation and whether that would even make sense. Now, of course, the problem is if they do it anyway and you have to challenge that, and is your institution willing to go through with that? So it's one of the reasons that we want to push back now and get some of this pulled back. But I don't know where what basis they would even use to make a citation on that. Did somebody ask about the inactive period?
Yeah, that's what they were asking. Does CMS differentiate between short and long? And I think we got the answer that it's 7 days, and there is no differentiating between short and long, to my knowledge.
Right. Yes. So an inactivation for them in terms of actual inactivity related to not retaining Medicare approval is 12 months. So you can have a fairly extensive period of inactivity during which you would be able to maintain your Medicare approval. You'd have trouble with UNOS sooner than that. But
Well, it looks like we have about 2 more minutes. Once again, the Alliance is going to provide you with a copy of these slides. I think any of us would appreciate any additional questions that you may have. Make sure that you use the listserv to communicate about this stuff, and hopefully we'll have more clarification soon. Kristine, do you have anything you want to say?
And there's just a comment from Jamie. Yes, some of the people on this webinar are having a call with CMS next week, and the American Society of Transplantation Transplant Administrator Quality Group will also be working with our legislative governmental people and drafting a letter to CMS about this.
Yay.
And I'm assuming ASTS is also going to get involved, particularly with the surgeon tag.
Well, I just want to say thank you to Gwen and Luke for joining us with your expertise to share your knowledge with us.
I always enjoy a chance to complain.
And Leanne, thank you for the Alliance for allowing this to take place.
Yes, absolutely. This was great.
This is a tremendous service to the community. We really appreciate it. Thank you, guys.
Absolutely. Happy to help, and thank you all so much for sharing. Just a quick note, we will, as Kathy and others mentioned, we will be sharing the PowerPoint presentation, and we'll also have the recording available. Deanna, is it going to be on our portal? We'll be emailing it out as well to all of you who registered and to the many of people that are on the wait list and couldn't get into today's webinar. But we'll make this presentation available, so you'll have a chance to go back and listen to it many times. Yeah. It'll be available, just to clarify, it'll be available on our YouTube channel as well as our community portal. So if you do have access to either or, you'll be able to view the recording there.
Thank you.
All right. To all of our participants, we also want to thank you for joining us today. And we welcome all of your questions, and we appreciate your participation. And we wish you a wonderful rest of your day. Take care.
Bye-bye.